a very interesting background. I have from the bio, started with a degree in theology and religion, lived and worked in the Middle East and Europe. I then trained to be a dietitian from the University of Manitoba, worked in Australia, worked with NGOs in Asia, came back to Canada working for the Winnipeg Regional Health Authority, doing a degree in healthcare management, and then moving into nurse management, doing a master's through the Faculty of Nursing and healthcare leadership while managing medical and surgical units. For the past 14 years, he's been on Vancouver Island working with Island Health Authority, managing patient flow at two tertiary hospitals in Victoria, and then transitioning into long-term care, looking at the health authority run long-term care sites. So with that, I will pass it to Philip.
Thank you very much. And can everyone hear me? Volume is okay?
Yeah.
Okay. And just starting off at, I don't have anything that would restrict my ability to be able to present this, as I'm just presenting information from Island Health. So I have no directive or nothing that I'm sponsored by. And so I wanted to talk about virtual care, and I've looked at some of the presentations that were done over the last little while, and I realized long-term care is one of those areas that not a lot of people know about, and me included, as most of my career was in acute care, working in hospitals, looking after emergency rooms, ICUs, medical surgical units, etc. But going into long-term care really blew my mind in regards to just understanding the complexity, how driven it is by ministry guidelines, by licensing, by all the different standards, let alone for the fact that long-term care is actually 19 and older. So you get a wide range of different complexities in terms of people that are 19 that maybe will be with the home for most of their life, or 20, 30 years, and maybe have MS and can't take care of themselves, or have aged out of different homes. And so today I just want to give just a quick overview of long-term care. And I'm speaking more specifically to Vancouver Island, give some stats and demographics, and what the pandemic changed for long-term care, and the need for change, and how virtual care is used in long-term care, how it's used in the island, and the future. So we definitely know we have an aging society. We just look at the stats, and there's, just for Canada alone, we're going to need over 30,000 long-term care beds in the coming years. Essentially, those over age 65 represent 16% of the population and 46% of our healthcare spending. And those in long-term care, are 7% of those that are age 65, representing about $31 billion we spend every year just on long-term care beds. There's definitely been an increase for the need of long-term care, as there's a number of people that are living in community, and we're working very closely with our community partners as well as our hospital partners to ensure people are getting the care they need to stay at home as long as they can. But with medical complexities and different concerns that our senior population is having, there is an increased need for long-term care beds. And just looking at some of the stats in terms of caregivers and those being able to take care of loved ones in their homes, or in other community care settings where they go into the homes, the challenge to be able to find staff and to find caregivers has definitely been challenged over the next few years, and the need for more caregivers is going up. But in terms of long-term care homes in Canada, on average, 50% of long-term care homes are privately owned. Privately owned, I mean, it's a combination of for-profit and non-for-profit, and 46 are publicly owned, meaning they're usually run by health authorities. And so just as I was saying, the breakdown of different long-term care homes in Canada, and you'll see that in BC, we actually have higher numbers of privately owned homes, and the island actually has a higher number on a percentage basis than most other health authorities in BC, where over 2/3 of our long-term care homes are actually privately owned, meaning either for-profit or non-for-profit. So just looking at the population of who's actually in long-term care, 2/3 or 2 out of 3 are women, and over 50% of the population in long-term care are over the age of 85. So just looking at Vancouver Island Health Authority, it's one of those health authorities that are kind of overlooked in the province, but at the same time, since provincial government is located in Victoria, there's a lot of observation of Vancouver Health Authority, and a lot of the health officials and our health ministers are either use the health system on the island or reach out to a lot of the health leaders. And so there's a very close connection with Island Health and provincial government, especially the Ministry of Health. And just to give a quick overview of sort of some stats, the island actually has about 850,000 people on the island. Just within Island Health is over 30,000 employees. For long-term care and assisted living, there's about 6,700 beds. Of those, about 6,000 are long-term care beds. 5,500 are publicly funded, meaning that we contract out. So there's 44 private homes that we contract out, meaning we subsidize those beds to allow the public to have a subsidized care. On the island, there's 17 homes representing about 1,800, 1,900 beds, from the Forward Island to Port Hardy to Lady Minto to Victoria, where the base of most of the sites are. So there's 17 homes across, total of 61 homes. Assisted living, very interesting on the island, is actually run privately. There's actually no owned and operated assisted living. And that is going to change the next number of years, because the criteria in terms of the care needs are very limited, meaning that if someone has diabetes and needs insulin, they can't go into assisted living. So meaning that more people go into long-term care that actually don't need long-term care, that actually could be cared for in the community. And so this is a change that Island Health is moving towards, is how do we actually better support assisted living sites for those individuals who just have basic medical needs, but don't need long-term care. And what we're finding is right now there's over 2,000 people on the island waiting for long-term care. The number is growing up every day. And so with that need, we're finding that Island Health actually has the highest numbers across BC, and BC has some of the highest numbers across Canada in regards to people in long-term care that actually don't need long-term care, that have either stabilized or have been added to long-term care by exception with very minimal care needs. Sorry. So I just want to quickly flash up the philosophy of care as a program, definitely focusing on connection, learning, integrity, collaboration, but the main focus that we're really trying to look at for long-term care is how do we have person-centered care, that we connect with families and have families as partners in care and are very much involved with the care of the residents. We know that with our owned and operated, because connected to more hospitals, they actually have higher numbers of those with complex needs, whether medically, behaviorally, etc., because there are some more resources available. So in general, usually the owned and operated sites that are run by the health authority have a higher level of complexity. And so even to my surprise, when I first went into long-term care, I was surprised at some of the services that are available, such as we have this respiratory unit that actually has trachs and vents. One of the first in the province to develop this program, and the staffing levels and the staffing model was actually then followed by several other sites in the mainland in terms of looking at what level of staffing needed, because the province sets out direct care hours of how many hours of care per resident per day, which is currently 3.36 hours. 3 of those hours are focused on nursing direct care, and the 0.36 are more allied care. And with a changing population, the traditional idea of long-term care is those elderly that are more end of life, and that play bingo all day. But what we're finding is there's a whole team of, or a whole new population of long-term care residents that are actively using, that have mental health concerns and need specialized care. And those who have lived on the street for years actually have years of addiction, and then have dementia-related care concerns post addictions. And we're finding age-related dementia is very different than substance abuse dementia. And so having to develop new units for specialized care is something that leads into what we're going to talk about in terms of the need for virtual care and how do we integrate that into our long-term care homes, and so that we don't have further hospital admissions or have residents that need to go for appointments off-site. And so just looking at some of the COVID stats on Vancouver Island, in terms of just how COVID was met, because it's geographically on an island, the cases didn't affect long-term care sites until a little bit later. So there was a lot of learning from other health authorities as well as from other long-term care sites across Canada. So it was managed quite well in regards to comparative data across Canada, where actually Island Health fared quite well in terms of just effective management of outbreaks and vaccinations, and we're able to run simulations before any outbreaks even happen. So there's great resources that were put in. But what happened was that because there was such a focus for the vulnerability of seniors, that there was an isolation of residents for almost a year where they weren't able to see family, and we had window visitations, and we had to implement virtual visits, which was extremely hard in terms of isolation for the residents and for families to not be with their loved ones, especially when they were passing. So what's happened, primarily due to the pandemic, virtual care has taken off in long-term care. So we have telehealth consultations, we do some remote monitoring. Mental health support is actually a very big thing, because residents weren't able to actually go to specialist consults and be able to meet with their counselors or psychiatrists. And so having virtual consults made a huge difference. Just when we talk about family communication, just the visits alone helped long-term care immensely, let alone having care conferences, which we'll discuss a little bit later. So in terms of mental health and well-being, as I've mentioned before, the population is changing. We're seeing a lot more increased agitation, a lot more violence towards other residents, towards staff. We're seeing a lot of increased staff injuries and staff going off. And so there's a huge amount of education that's going into long-term care and our healthcare system is in terms of violence prevention, but also approach. 75% of the staff in long-term care are healthcare aides. And for the healthcare aides, they are very task focused, meaning they have a list of things they need to accomplish. Getting the resident up, dressed, pericare, etc. And with this changing population, especially those with addictions or mental health, having the approach of someone coming in and wanting to give you care right away has had its challenges, especially in agitation and violent responses. So the ability to have the right approach and giving that education for the staff has made a big difference. And that's definitely what has to happen over the next years. So again, mental health support has been tremendous in terms of having the virtual care, the family communication, especially for families that need the updates. They want to be able to connect with the clinical nurse leader or the nurse on the floor, how their loved one is doing, what is going on, are they eating, etc. So we've seen a lot of benefits. We used to have in-person on-site training for new staff that would come in. We've moved a lot more to regional education and training. We still have the on-site education for brand new staff, but we can actually have more regional approach. And this is really important for the rural sites where they don't have a clinical educator on site. They don't have the same level of staffing as in the urban centers. And so the virtual education has been a godsend for a lot of our staff training. And even health education for residents, being able to just have that connection with a health provider virtually, where we don't have on-site staff that can come in. Our physicians, what they did during the pandemic was they had one or two physicians that would come in on a regular basis and then take care of all the other residents. And so sites that are quite large, where we have 320 residents, it was very difficult for physicians to actually physically come in. So having the virtual care made a big difference. And even in terms of emergency response, having the physicians be able to triage with other consultants, such as if they think that someone's having a stroke, they can actually have a virtual communication with a neurologist and have those discussions about if the person's advanced care plan is to give just comfort care and not send to hospital, what's the best treatment? And that's where we look at care planning, look at more specialized care, and each resident, each person is unique. And this is, I like this picture because it very much shows that a lot of our residents are nonverbal, not able to whether speak for themselves, are not mobile. We think of some of the residents that have complex neurological conditions where they are capable, but physically they're not able to be transferred to go to a consult, to go to medical imaging, etc. And so having the virtual care has made a huge difference for those individuals. We look at medication management, and for some of those you've maybe seen on the news in the last little while, there's a big awareness now that the appropriate use of antipsychotics. And we've known that within long-term care as a lot of our residents get transferred directly from hospital, may have a hospital visit while in care. Some antipsychotics have been prescribed. When they come back to the site, it's so important to review the medication. And so a lot of times when residents have been transferred to hospital for procedure or emergency consult, that they can actually have that video conference with, say, the emergency doc, with the hospital doc, and and talk about the medications and the electronic health record, which I know there's been a lot of sessions about that. And I'd love to actually have a future session about how the electronic health record has made a huge difference within long-term care and how it's used differently than it is in hospitals. But just having the virtual conferences for the care providers, for the specialist, the case management, and as I was saying, for the medication review. And now we've implemented a lot of 6-month drug reviews to make sure that those coming in to long-term care that we actually review, because sometimes we see people coming into long-term care that have, 12 to 15 different medications. And do they actually need all of those medications? Do they need the antipsychotics that were prescribed to them while in hospital to help control some behaviors? And so that's why there's a big movement within long-term care, and it's one of our health authority goals, is to how do we reduce the inappropriate use. We know that there is appropriate use for those who maybe have are in psychosis, have hallucinations, actually have a mental health diagnosis, and there is a need, and that's why we want to make sure that the appropriate people are getting those antipsychotics, because we know it definitely reduces the quality of life. And we hear from loved ones that they come in and see their loved ones are, as they say, snowed and not the same person because they're on antipsychotic medication. So what we've done as of recently in long-term care, and we're really looking at how we can improve the service, is we have specialized nurses that have certification in wounds, ostomy, and continence care. And so we have 2 on the island, one that primarily works with our owned and operated under the health authority, and one that primarily does consult support long-term care sites that are privately owned. And so just by sending an email, they have a virtual appointment, they're able to virtually connect with the nurse. The device that we're using with most of our sites are essentially, it's an iPad on a stand with wheels that can be wheeled right into the room. And the virtual appointments include sometimes the family or other support people, the clinical team, and we go over the plan of treatment. And this is really important for wound care. And we're looking at pressure ulcers. We see those residents who have been in a hospital for long periods of time, and they haven't had a lot of activity. They haven't been able to move around and have exercise. And so what's happened is the pressure ulcers and wounds become quite unmanageable, and the need for wound care is greatly needed. And so with that, we've also introduced a SWAN program, which is a skin wellness associate nurse program for our LPNs. And with a shortage of nurses and other healthcare professionals throughout the system, the need for getting our LPNs up to full scope by having some of these programs has made a big difference, because with some sites not even having a nurse on site for that shift, our LPNs have had to step up and fill in for a lot of the consults and admissions and some of the medical oversight that our RNs would provide. And just for access for the residents to communicate with staff and get that treatment plan in place. And we've been able to implement a pilot at one of the largest sites. It's the largest publicly run long-term care site in Western Canada, which is 320 beds. And we did a pilot. We've done a number of pilots there, but one of them is actually having a physiatrist who comes in. Originally, it was virtual care. Now he's able to come in with his team, meet with the nurses. They have pre-scheduled appointments with those with wounds, and looking at developing different specialized treatment plans. And this has made a very big difference. So family conferences usually happen once a year with residents, and historically the family members would come in, and we've actually brought that back. But we have family members that are sometimes living in other countries. We have a lot of family members that say live in the States or aren't able to physically be there. And so virtual care has made a big difference. And for the family care conferences, it's a way to not only look at, what medications are they taking, but have the entire team, the recreation therapist, talk about what activities are they involved with? Do they want to be involved with activities? Are they getting exercise? Are they getting movement? What's their social interaction? How are they connecting with other residents? There's definitely, some residents that have chosen to exclude themselves from everyone and isolate themselves and have gone into depression and just want to stay in the room because they're not happy that they've had to go to long-term care site. And we've talked to a lot of people, that are in sites and the general population, and most people don't want to go to long-term care. Most people prefer to be at home until their final days, but medical complexities and other concerns require people to go into care where they receive 24/7 nursing. And so having the dietitian, the social worker, the pharmacist, the physician, having physician engagement has been huge. Having the nurse, even our healthcare aide that work usually with that resident, connect with the family, give an overview of what's been happening, how are they eating, have they been losing weight, what's their appetite, has made a big difference for families to be aware of what's going on with their loved ones. And having this ability during COVID by virtual care conferences, we've heard nothing but appreciation from our families. And, it's very rewarding when family members for a period of time weren't able to come in, but were able to actually connect with an entire interdisciplinary team and see their loved one and hear what was happening. And as much as we can, we really try to have the residents part of that conversation. It makes a difference for those that are capable. Another service that was implemented during COVID was the interpreting service. Historically, we would make arrangements, whether via phone, or sometimes in larger urban centers, we'd have someone come in and provide whether language interpreting service for those who are, say, blind or hard of hearing, provide interpreting services, but having the virtual interpreting service, which is available for the province, and was actually able to have access to so many more languages, has made a big difference. And we've heard gratefulness from the staff just to be able to make a call and have someone available within a very short period of time. And for the fact that it's provincial, gives a larger pool of people that are available to be interpreters. So I want to just put up a little diagram just to see how virtual care is in action. And this is more of a healthcare setting, but as we said, long-term care has a lot of medical complexities. We have subacute medical floors where people are receiving highly complex medical care, very similar to what they've received in hospitals, but we know we can't keep people in hospitals indefinitely. And so we need to have those specialized care units. And so just for patient education, for online bookings, for virtual visits, for all the other needs for a healthcare facility to improve patient experience, for access, for having those services available where they live. And we know every time we move someone that has dementia, and one of our sites had a number of floods and construction concerns, and we've had to relocate people to different locations. We've noticed those, and through data is shown that every time you relocate someone, that post-move, the agitation and cases of violence have increased. And so every time we've had those emergency situations and we've looked at the violent incidents, they've actually gone up substantially. And so keeping people where they live in their own room makes a big difference in terms of the decreasing relocation stress. So telehealth is provincial service. Island Health has developed a team that we work very closely that not only provide the actual equipment, but provide service and support to the nurses to be able to work with the physicians and other teams. And so the provincial program, as implemented now in Island Health and other health authorities, is a joint program that works very closely together. And then each health authority has actually developed and modified the program. And these are just some of the other areas that the health authority is using, for the virtual visits, especially for those wanting to stay at home and that don't have the ability to either go to a family physician or don't have a family physician. This is one option that will make a big difference for the future for those wanting to stay at home longer, but don't have that family physician and have that medical support to be able to stay at home longer. Makes a big difference, as well as supporting the community workers. A number of long-term care facilities have started using this device and other similar devices, and some families have actually implemented air tags for their loved ones, especially for those who wander, for those who are like to elope. This has been a great resource just to be able to have the ability to keep track of where the residents are. And there are definitely some residents that that you wouldn't be able to know that they're residents. And so when you have visitors come on the unit, they're quite deceived because they have their normal clothes on, and they let them through the door, and they're able to actually leave through the front door. And so the geolocation tracking has made a big difference in those individuals who like to wander. Just having My Health 24/7 access to laboratory results and medical imaging and different outpatient appointments has made a big difference, especially for ambulatory clinics and those needing other services post-hospital admission. As I said, the remote patient monitoring, the monitoring makes a big difference for those wanting to live at home longer and for those caregivers. So the future of virtual care and long-term care is quite interesting, as I think it's going to continue to expand. It's going to continue to use other technological advances. The integration within our long-term care sites not only are publicly funded, but as well as the private sites, and having support from the health authorities to be able to have the virtual care in the private homes has made a big difference. And there's been provincial funding to help support that, so that a private long-term care facility will be able to access those resources, which has made a big difference, especially for those private sites that are contracted, meaning that we've subsidized a number of their beds. We give them funding for their health needs, as well as most sites with the nursing shortages have been relying on agency nursing. And the challenge with agency nurses is that they're there for a short period of time. They come to a facility, they don't know the residents like the regular staff. And so having virtual care and virtual connections to other professionals that know them, such as their provider, whether it's their physician or nurse practitioner, makes a difference in terms of getting the specialized care programs that have been in place for those residents. I mean, just for the privacy and security enhancements has made a big difference, as well as the remote monitoring and wearables. I wanted to also talk about other technology that we're starting to see within long-term care and the benefits that we're seeing. Virtual reality is just and cognitive simulation, having activities and learning memory games, other engagement that is great for improving the quality of life for those with dementia, as well as just having interactive experiences has made a big difference. Robotics, the number of robotic pets that we are seeing now in long-term care, and whether the family is purchased, we have a number of foundations that have made donations of these pets, and the pets can be quite expensive when we're looking at anywhere from 500 to 1,000 or more. But the amount of decreased agitation that we've seen from those residents with dementia by having a robotic pet, the data is quite amazing to see. And even just visually seeing and seeing and talking to those residents that have their pet and go around using the wheelchair with them and see the smiles is almost just worth it in terms of just the financial investment that we're seeing. And we know AI and predictive analytics will make a big difference in terms of predictive models, and especially for personalized care plans. As I've talked about, the population is changing, not only for the medical complexity, but for their behaviors, but for also the type of dementia that we're seeing, especially for those who have dementia related to their addictions, and especially those who continue to use substances within long-term care, as it is personal choice. We're able to have personalized care plans and work very much with research and different universities to develop new innovative ways to support residents with different forms of dementia. I mentioned about robotic animals, but the other big technology that we're seeing within long-term care, the name is Snoozlin. That's just it's a brand name of a company that from Scandinavia that's developed multi-sensory environments. So whether different lights, different images, different pictures of the resident that can be uploaded, that we use a lot for memory care. We have a lot of sites have physical memory boxes. So when someone with dementia is getting a bit agitated and we give them a memory box of pictures and different items from their past, we find it very calming and soothing by having an environment where we can put different pictures and different tactile stimulation has made a big difference, especially those with neurological concerns or diseases that have been in long-term care for long periods of time, shown great improvement. And so again, as I was saying, we've been looking at some research in Japan and Korea in terms of the use of robotics and connecting with residents and looking at how seniors have been responding to robotics has actually been quite surprising, because I would have thought that there would be a resistance and not actually embracing the robotics, but have actually been quite the opposite, and they've embraced and loved having the companionship. The number one concern that we hear from all long-term care sites, all leaders, all frontline staff, is that majority of our recreation staff, our occupational therapists, our regular staff work Monday to Friday, 8 to 4. Same with our leadership, our clinical nurse leaders. But we know that healthcare is 24/7. And we know that through the historical data that a lot of residents, especially with dementia, start sundowning in the evening. And that's why it's been referred to as sundowning, as usually 5 or 6. Agitation increases, people are wandering. We don't have the staff on site that actually can provide companionship and provide any kind of entertainment. And so as much as we've tried pilots at different long-term care sites across the island to have after-hour support for evenings and weekends, we haven't been able to get the staff, and especially for some of the more rural areas where they don't have recreation assistants or recreation therapists, to have other people come in. But having virtual care, having the stimulation, having robotics, etc., that can engage with the residents and have the companionship. We've seen a decrease in volunteers at long-term care post-COVID, and we haven't seen the return of those volunteers, as most of the volunteers were aging themselves and had medical concerns and were quite concerned about coming back into long-term care facilities. And even in terms of student volunteers, we haven't seen the return of students. So we've had to look at other ways of engaging residents after hours. And so the idea of virtual care and virtual engagement sessions and entertainment, and I think is what we're going to start seeing. And yes, there's investment, but the data and research is showing that it's making a big difference in terms of the care of the residents, and decreasing agitation and offering lower stimulation. And so we continue to look for different initiatives. We've seen different foundations purchase different equipment. During the pandemic, most of the foundations in the island actually purchased so many iPads just for communication for the residents and the families, that it made such a big difference. So even partnering with private organizations to see how we can have new technology in long-term care will make a big difference for the future of long-term care. So in conclusion, the future of virtual care in long-term care will continue to increase the need for virtual care. The virtual experience will continue to keep going, and innovation is what's going to be needed for those that are actually needing long-term care, as we try to keep people home longer. Those who eventually do go to long-term care have a lot more medical concerns, dementia-related behavior, etc. So the complexity is increasing. So need for new innovation is greatly needed, and I see a great change within long-term care. And I think going to long-term care sites in the future will be quite surprising for a lot of people who have outdated images of how a long-term care site is, or historically called nursing homes, where people are sitting around playing bingo. And I think the future will be seeing people engaged in physical activities, and maybe having virtual reality glasses, having virtual assessments by their specialists, is the wave of the future. So I'd open up for questions, whether it's related to long-term care in general. I find a lot of people are quite surprised, or even just unaware of